On March 5, 2020, the Faculty of Medical Sciences Teaching and Research Complex, the UWI Mona campus, held a conference entitled COVID-19 Pandemic Preparedness. To give an overview of COVID-19 is Professor Celia Christie.
Before this, there were 6 coronavirus species which were known to cause human disease. The 4 common ones are the ones that cause the common cold and cause respiratory illnesses. And then there are 2 fatal zoonoses that came to attention. The first is SARS-CoV, which caused SARS outbreaks in China. And there were over 8,000 cases reported, of which 10% of these persons died. There's also the MERS-CoV virus, which caused SARS in 2012, and there were over 2,500 cases reported, and 35% of these patients died. And then, somewhere in the middle of December, reports of clusters of 27 patients with pneumonia of unknown cause, of which several were linked epidemiologically to a seafood and wet animal wholesale market in Wuhan, in the province of Hubei in China, were identified. On the 31st of December, Chinese CDC essentially conducted an etiological investigation, and the novel coronavirus was identified in the BAL fluid of 3 patients with pneumonia, whole genome sequencing by direct PCR and also by culture. And the phylogenetic analysis showed that it falls in the genus of the beta coronavirus. As you can see here, we have photographs of the cytopathic effect in the human airway epithelial cell cultures, electron microscopy photograph, and also we have here the full-length phylogenetic analysis of the virus showing where it fits in the whole scheme of the other beta coronavirus genomes. So as of this morning, there were some 95,315 cases reported, confirmed around the world, of which 3.4% or 3,282 were related to deaths. In China, most of these cases came from China with over 80,584, and that accounted for a little over 3,000 deaths. The top 4 countries that are now struggling with this epidemic and with endemic transmission include South Korea, with over 5,000 cases, Italy, with over 3,000 cases and quite a few deaths, and Iran and Japan. The cruise ship off the coast of Japan is also of interest, because there we had 705 cases, of which so far 6 patients have died. We also hear every evening on TV about the cases in the United States, now up to about 160, with 11 deaths. And we know now about several cases that are now being reported from Latin America and the Caribbean. This epidemic now affects over 87 countries or territories around the world, except for Antarctica. So, a wet market is a warm market where recently slaughtered animals are made available as exotic foods in some parts of Asia. And the Hunan seafood market in Wuhan was banned in the 1st of January by the Chinese government because the majority of these cases, not all, were possibly linked to this animal market. The patients were mostly shop owners or visitors to the market. And since then, it has been felt that bats and pangolins are the possible culprits. It seems somehow, as I said before, that COVID-19 seems to be a recombinant virus between the bat coronavirus and an as yet unknown origin-specific coronavirus. One animal was the snake, and that was published in the Journal of Medical Virology, but the academic community discredited that paper. And then more recently, some notes from Nature, one of the world's leading scientific journals, suggested that pangolins may be implicated. Pangolins are used in Chinese medicine to help with ailments ranging from lactation difficulties to arthritis. The scales of the pangolin are typically dried and ground up into powder and turned into a pill. Researchers feel that this may be the missing link between bats and humans because the genetic sequences of the virus show a 99% similarity with the pangolin. And then some are wondering, did the virus escape accidentally from the Wuhan Institute of Virology, China's national BSL-4 lab, which was studying bats and such bat-related viruses there? This is a theory. It's just a theory, which is undergoing scientific investigation as we speak. So, did COVID-19 cross the species group from bats to humans? And if so, this definitely is going to be terrible as it relates to human pandemics, maybe what we're experiencing now. The transmission of this virus is uncertain. The basic reproductive number is somewhere between 1 to 4 infected persons per symptomatic case, as compared to measles, which the number is 18. The incubation period is 2 to 14 days with a median of 5 days. Among the first 422 cases, 55% had an onset of illness before the 1st of January, and these were linked to the wholesale food market, compared to 8.6% of subsequent cases, which were possibly person to person. Transmission that we all know now is by respiratory droplets, by direct or indirect contact. It is spread by touching our mucous membranes, the conjunctivae, the mouth, and the nose. It's also detected in blood, urine, feces, and in aerosolized respiratory secretions. It lives for about 5 to 7 days on environmental surfaces. Asymptomatic transmission is strongly suggested, but infectious disease experts would say that epidemics are mostly driven by symptomatic persons with a higher viral load. Clinical features in the first few hospitalized cases, in other words, patients that are very, very severely ill, we see where men were mostly involved. We see where 30% of these had underlying diseases. The median age was 49 years. 66% of these were exposed to the seafood market, and there was just one family cluster among these. Initial symptoms are shown here with fever, cough, muscle aches, or fatigue. Shortness of breath occurred in 55%, and 100% of these had pneumonia. ICU patients were found to have higher plasma levels of the following cytokines as compared to those who were not admitted to the ICU. Complications in the most severe cases included acute respiratory distress syndrome in almost 30%, acute cardiac injury, secondary bacterial infection, ICU admission in 30%, and unfortunately 15% of these patients died. And again, this is in a setting where they have the best possible health care that is available. Among 44,000 plus COVID-19 cases from the community that were confirmed, 83% of these now were mild, 14% severe, and 5% critical. Notwithstanding, the case fatality rate here was 2.3%. The majority of the fatalities still occurred in persons more than 50 years, and underlying diseases were still prevalent in about 30% of the group, as shown. For those who were aged less than 50 years, very few of them died, which is 64. Among over 70,000 plus cases now that were reported, children are rarely found to be affected. Only 2.4% of these were less than 19 years of age, and there were no deaths in children less than 9 years of age. Children were therefore felt to have a lower infection risk than adults, but what was really happening is that the children were on spring holidays, and then before they came off holidays, they were put in quarantine. So could it be that they were less likely to be exposed? Or could it be that children have cross-protective immunity from the 4 common coronaviruses? Could it be that their symptoms are not as serious as their adult counterparts? Or could it be that their cells are less hospitable to this virus? Could it be also that children are asymptomatic, but they still shed the virus, as has been shown in this particular cluster? One question I have, though, is could it be that the children and the women were indoors, and it was the men who were most likely to be exposed? Because in the initial cluster, you'll remember it was 71%. Other special populations that we've been hearing about include the cruise ship off the coast of Japan, where 20% of persons to date have been infected by the virus. Then there are now several unlinked epidemics to China contacts that are developing around the world. There are epidemics related to religious organizations and clusters of prisoners. In the epidemic in South Korea, it is reported that half of the patients were linked to a particular religious group. Healthcare workers are at the forefront of this epidemic, and there was very early on an initial cluster of 15 reported. Since then, among the 70,000 cohort, it was found that 1,716 medical staff were affected by COVID-19 for 4% of all cases and 0.4% of all deaths. Pregnant women, as I said before, are not many. I think we have just about 21 pregnant women that are reported, and so far there's no conclusive evidence for mother-to-child transmission in 9 pregnancies that were reported in the Lancet. So, having completed the phylogenetics and sequencing of this virus, within 1 week, an RT-PCR test was developed for diagnosing it. The initial CDC test kits you would have heard are flawed. Notwithstanding, we still have several diagnostic labs in the Caribbean, including here at UWITV, not using the CDC test kits. We are now working, meaning we industry, on point of care rapid tests for use in the field and at the bedside. There is no known treatment for this illness. There are no known vaccines for this illness, to prevent this illness. However, using our experience with SARS and MERS and Zika and Ebola, and more recently with HIV and even influenza, several suggested remedies are being used. Remdesivir is the one that heads the list. Lopinavir, ritonavir, or what we know as Aluvia or Kaletra, is also helpful and is being used with oseltamivir, or what we call Tamiflu. Chloroquine phosphate emerged just last week. This is a drug that we use for malaria to have some apparent efficacy against COVID-19 pneumonia in clinical studies. We have over 20 vaccine trials that are now in progress for this particular agent. Here at the University of the West Indies, we have also joined in the initiatives. Countries which already have a strong research platform for looking at emerging infectious diseases, and for us it's the Zika. We are complementing studies that are already on the ground in Jamaica, in Nigeria, in Laos, and Thailand. We're providing data, hopefully, on maternal, pregnancy, and birth outcomes during these outbreaks. And we are using this opportunity to help communities, or to continue to help our communities to prepare during emerging infectious diseases outbreaks. Over 60 million people were placed in quarantine in China, and this was mandatory and enforced such that Wuhan was found to be silent. There is a total lockdown on travel. Schools are closed. Persons are working from home. All events were cancelled. We're moving from containment to mitigation. And we should say that it is said that over 5 million people left Wuhan before the coronavirus quarantine began. The live animal markets closed since January. And 2 hospitals were built in 7 to 10 days, and these were used to augment other hospitals that were designated for patients with the most severely ill patients. Other hospitals were also set up where stadiums, exhibition halls, and so on were repurposed into hospitals for patients who were not as ill, didn't need a ventilator, where they could get medications that would hopefully prevent progress to severe illness, where they could be isolated, and for those who were contacts and were not yet ill, they could be placed in quarantine. Hand washing, mask wearing, and care seeking were the 3 tenets of what was being suggested there. And the military medics, as you know, have taken over the management of hospitals in the hot zone in China. For hospital infection control and prevention, personal protective equipment, hazmat suits, disinfectants, good infection control and prevention methods are being stressed. Pharmaceuticals, medical supplies, diagnostics, therapeutics, clinical trials, and research are also being explored. Education and training is also ongoing in the population among healthcare providers and others. As of the 30th of January, you know that the WHO declared a public health emergency of international concern, and to date, countries from all continents are now involved, and several are experiencing sustained human-to-human transmission, and several are experiencing several deaths. So in summary, COVID-19 caused clusters of severe respiratory illness similar to the SARS coronavirus. It has a wide disease spectrum. It's associated with ICU admission and a high mortality. It has caused a rapidly changing and unpredictable situation, even as new outbreaks are coming on board in several countries, including Iran, North Korea, Italy, and even in the United States. We are now seeing cases here in Latin America and the Caribbean since the weekend, and I guess this is why so many of us are interested. But still, there are major gaps in our current knowledge of the origin, the epidemiology, the duration and methodology of human transmission, the clinical spectrum of disease, diagnostics, therapeutics, and vaccines, and even how to set up healthcare services, primary, secondary, and tertiary healthcare services for something as devastating as this that could overwhelm our ability to conform. As of the 25th of February, the CDC has said that COVID-19 and the SARS-2 pandemic is imminent. And in their words, not mine, they say it's not if, but when. The WHO keeps holding off, but I guess it's economic. But in the meantime, they're saying prepare, prepare, prepare. All countries should prepare. And our own UWI graduate, Dr. Carissa Etienne, the director of PAHO, is asking us to continue to work to strengthen member states' capacity throughout the Caribbean and the Latin American region to detect, contain, and manage cases. Thank you.